Centenary, as you know, is a longtime presence in Shreveport. We take our responsibility to the community very seriously, and we are so happy to be able to provide expert information and guidance in these crazy times. And I am honored that you've taken the time to join us, and I'm particularly pleased to have such a distinguished panel with us. As you've seen from the housekeeping slide, we are recording this and it will be available later. We are gonna go for about an hour, as long as people have questions for that long. If we take the time, we'll stop at 7. We're gonna have some conversation with our panelists. If you would like to ask a question, we've already gotten some questions prior to the panel, but there is a Q&A button at the bottom of your screen. And if you click that, you can fill in a question, and we'll stop every so often to clear up any questions that are in the queue. That's also the button you would use if you have technical difficulties. We do have help behind the scenes that can help you troubleshoot if you're having issues with Zoom. We do ask for your patience if we hit any snags. We've all been recipients of a lot of Zoom meetings, but not all of us have been content providers, as they say. So we will do the best we can. I'm going to introduce our panelists briefly, and then we'll start our presentation. First, Dr. Joseph Bucchini is a longtime resident of Shreveport and a distinguished physician, an experienced pediatric specialist. Dr. Bucchini received his medical degree at St. Louis University School of Medicine, completed a pediatric residency at the University of Connecticut, and a fellowship in pediatric infectious diseases at the Johns Hopkins University. He's also a veteran, having been in the U.S. Army Medical Corps. He came to Shreveport and has had a long career and distinguished career at the LSU Science Health Center. He was, in 1995, appointed medical director of Children's Hospital of the LSU Health Sciences Center, Shreveport, where he continued in that role and also as department chair and other roles for almost 25 years, if my math is right. He has received many accolades over the course of his career, and also performed valuable service to professional organizations. Chairperson of the American Academy of Pediatrics Committee on Infectious Diseases. He was awarded the Childhood Immunization Champion Award in Louisiana in 2017 from the CDC Foundation. And in 2019, he was honored by his selection as a master pediatrician by the Louisiana chapter of the American Academy of Pediatrics. But the thing he should be most proudest of course, is that he has a daughter who is an alumna of Centenary College and perhaps is in the audience. And so we give her a shout out. So welcome, Dr. Bucchini. We're glad to have you with us. Dr. Patrick Massey is a pediatric sports medicine surgeon at Shriners Hospital for Children in Shreveport. He earned his medical degree from Jefferson Medical College in Philadelphia, did his residency here in Shreveport, which included a rotation at Shreveport Shriners. He's also completed a fellowship in sports medicine at Houston Methodist Hospital. He is a board certified orthopedic surgeon and also in sports medicine. We are very grateful to for Dr. Massey's help. He has been an amazing partner for this year with Centenary and helping us learn how to stay safe and keep our athletes safe and be prepared to have intercollegiate competition. And that has just gone very well. In fact, off topic, but one of our student athletes was the conference player of the week last week for our basketball team. So thanks to Dr. Massey for getting our sports teams ready to go, and all sorts of other really valuable advice. And last but not least, Dr. Rebecca Murphy is an associate professor of biology here at Centenary. But we are also very proud to claim her as an alum as well, receiving her Bachelor of Science in Biology in 2006. She holds a PhD in biochemistry from Texas A&M and has been with us ever since. And we are glad to have been able to hang on to such talented faculty members. She is legendary on campus for a variety of reasons, her teaching, her research, and the clever way she makes use of her skeleton model that appears in various places around campus. Her research is directly relevant as she has received funding from the National Science Foundation for several projects involving RNA and some of the other things that we will talk about. So without further ado, I will say welcome and thank you to all of you for your expertise. And I'm going to turn first to Dr. Bocchini, who's maybe going to give us a little bit of an overview, just sort of what the current state of play is with regard to the virus. Where do we stand with regard to infections in the state and our region, and other sort of current events information you'd like to share.
Well, thank you, Dr. Holloman. Can you hear me okay? We're good. Okay. Well, thank you for putting this on, Dr. Holloman, and thanks to Centenary for making this time available to help the community understand where we are with this pandemic and the role that vaccines are going to play in us controlling it and containing it. So, as you all know, it was just a little over a year ago when the first cases of COVID-19 occurred, and just recently, we now have passed a milestone where there have been over 100 million cases of COVID infection documented throughout the world and 2 million deaths. So we have a rapidly spreading serious infection that has encompassed the world in causing serious disease and death. In the United States alone, we have over 25 million documented cases, and we recorded over 400,000 deaths. So 25% of the deaths associated with coronavirus COVID-19 have occurred in the United States. So we have widespread viral activity continuing in the United States right now. We're in the middle of our third wave. This is the worst wave. We have the highest number of cases per day. We have the highest number of patients in the hospital with COVID. And we have the January so far has turned out to be the most fatal month in terms of COVID cases. So we are in the middle of a very serious portion of the third wave. Only good news is that over the last week, the number of hospitalizations has actually dropped a bit across the country, and the number of deaths has slowed, but we're still over 2,000 and sometimes 3,000 deaths a day associated with this virus. Now, Louisiana has basically followed the pattern that's in the United States. We have had a recent peak. In the last week or so, we've seen a significant beginning of dropping in the number of cases and the percent of positive tests that have been done. But just looking at the most recent data from the Louisiana Department of Health, we currently have 1,625 patients in the hospital with COVID. 203 of them are on ventilators, so seriously ill. And we've recorded over 8,600 deaths in our state. So we do have widespread activity within our community that is ongoing with perhaps a small degree of improvement, but not enough for us to feel comfortable. In terms of variants, you've heard a lot about variants in the press over the past month or so. And I know that Dr. Murphy is going to talk a little bit more about this. So I'll just kind of give an overview. Viruses, when they cause infection, duplicate themselves millions of times in the course of an infection. And because that process is ongoing, there are a number of errors that come into the genetic makeup of the viruses. These are mutations. Most of the mutations mean nothing. Some of the times the mutations cause the virus to be less efficient. In other cases, it gives the virus a better opportunity to do things. And so we've seen some variants that have developed that appear to be more spreadable, and more easily spread. And we're trying to understand why that's the case. But it is important because when those viruses spread within a community, they have an advantage over the other variants in the community and can spread more rapidly and therefore take over. So one of the concerns we have is that in the United States right now, there are at least 25 states that have identified the variant from the United Kingdom that is more rapidly spreadable. The good news so far is that we're getting some preliminary data that the vaccines that we have produced are still going to be effective against this variant and the others that are now appearing. And some of the treatments that we have, especially the monoclonal antibody treatment that's now available, is still likely to be very effective. So at least we have some good news. And if we can get better control of the spread of the virus, so we reduce the number of people infected, we would hopefully reduce the number of variants that are likely to continue to develop.
Thank you. That's a great overview. And we're getting some really good questions, and keep them coming in. A lot of questions about the vaccine and how it works and how we get people vaccinated and so forth. Before we get to those sort of really super practical questions, Dr. Murphy, I'm going to turn to you, and maybe you can help those of us who are not scientists understand a little bit about the virus and especially about the vaccine. And I think some of us have heard that it's a really different kind of development or a different type of vaccine, and this whole idea of messenger RNA. Help us understand a little bit about the science, and maybe we can use that as we then turn to some of these questions about how do we help people understand the safety of the vaccine or whatever. So, but help us out, Doctor.
Thank you, Dr. Holloman, for the introduction at the beginning, and thank you, Dr. Burkini, for an excellent lead-in to my part of the questions I'm going to answer. So I think there's kind of several questions embedded in there. Really, I think you could start anywhere, but one place I think that's probably really useful to start when we think about RNA vaccines, these new type of vaccines, is to understand kind of the background or research that is going to underlie some of these things. Me, just like many of you, like I really thought when I first heard mRNA vaccines, even though I'm extremely familiar with RNA as a molecule, this was, sort of news to me, it being used in a clinical setting in this particular way. And so it actually has pushed me to read a lot of interesting literature and catch up on some of the gaps in my own knowledge. And so I think this idea that this is a brand new technology that we've never ever seen before, and it's kind of scary because we've not tested it, that actually turns out to not exactly be true in a lot of ways, just because a lot of the research has not been in the public eye because there wasn't a pandemic going on prior to this. So I think really this RNA as a vaccine, this type of research trying to get RNA delivered into a person and allow it to be therapeutic. This is really beginning back in the early 90s. People started working on this. And so a lot of the RNA research that we've looked at is not so much about it as being safe. So we can also discuss some of the safety things related to this vaccine, of course, at some point during the webinar, but is actually related more to the stability of the molecule and trying to get it delivered in an appropriate way so that it's effective. So I think many of you have probably heard that the Pfizer vaccine must be kept at -80 Celsius, which is extremely cold. It's much colder than a regular refrigerator. And this is again due to stability. And so what we really want from a vaccine just in general is for it to be stable enough to get to the place it needs to go and do its job without being prematurely sort of killed by your own immune system until it gets to the part that you want your immune system to practice, and that's going to be on the actual spike protein itself. So because RNA is so delicate, most of the research really focused on how can we get this as an intact molecule? How can we make this molecule as much like our natural RNAs as possible so that it will get to the place that it needs to go? And some interesting things that, again, a little bit new to me in terms of a therapeutic sense, a lot of these technologies have sort of, again, flown under the radar because some of them, nothing ever came of them. So for example, there's actually been a vaccine for rabies that was an RNA-based vaccine it actually made it to sort of the first stages of human trials. And this was in maybe 2017 or 2018. And it wasn't ended necessarily for safety reasons, but because it wasn't effective in providing those protective antibodies. We've seen a couple of other types of vaccines being tried with this technology, including for the Zika virus. So it's not necessarily that this is new, but it wasn't news, I think, really for the general population. So there's really been a lot of research into this, getting this delivered in a safe way. But the fact that this is a pandemic has really upped the exposure that we're all having to COVID. And so that's going to be one of the reasons that we can see this accelerated success for multiple companies. So, you know, the first instinct that this is something shady, it's really not the case. There have been decades of research into this, starting, you know, in the 90s. So the way that I think this leads kind of nicely into the way that this vaccine works. It is a little bit different than some of the other vaccines that we routinely take in the public's eye. So most of the, not all, but most of the vaccines that we're accustomed to getting involve some type of attenuated or weakened virus. So getting actual virus, but it's a little bit weakened or modified in some way that so that it can't cause you illness, so that your immune system can practice on the shape of those molecules. So it's all about fitting to the shape of what they're going to be seeing, these invaders. So we send in these weakened viruses that can't do much, and that's the normal way we think of vaccines. What these RNA vaccines are going to do is actually allow you to create these proteins yourself naturally in the cell. So I like to think of, you know, DNA as being sort of like the master cookbook. And some of you guys may have seen my Facebook post about this. RNA is going to be a copy of any recipes in that cookbook. And then something like the viral spike, that would be like the microwave fudge, I think was the example that I used. But that's going to be the product that we get. And so by delivering this RNA, we're actually just allowing this production to be a lot quicker. I could really go into details about this all day, but I think for now, leave it a little bit more superficial so that people can have time to ask questions. But the basic idea, I think, is that you're going to have RNA, foreign RNA in your body, whether you take this vaccine or you have COVID. There's going to be RNA in there one way or another. This allows your immune system to produce the proteins that it needs so that you can practice on that before encountering a live virus that's going to actually do damage to your cells. So I think I've kind of covered two of the topics that I think Dr. Holloman mentioned. So again, I don't try to give kind of a brief overview just so that we have time for questions or lead into another topic.
You know, let me follow up a little bit on that, but with one of our physicians. So, so Dr. Massey, if I understood what Dr. Murphy said and what I've been reading, yeah, although someone who gets the vaccine may have some side effects, either just muscles, you know, from where you got jabbed or from your immune system kicking in, there's not really a risk of getting the COVID virus from the vaccine because it's not an attenuated version of the virus. Is that accurate, or have I butchered the science?
No, that's absolutely correct. So, you know, some of the really old original vaccines, the live attenuated, there is a very small risk, and with the newer ones, I mean, almost minimal risk, if any. But with the mRNA vaccine, there's zero risk of it creating the virus. It's only programmed to make a small little piece, what she's talking about, the spike protein. And so it's gonna encourage your body to make little small tiny pieces of what the virus would end up making. And so it can, which is more virus, so it can recognize the virus when it comes to try to invade you, and then it can attack it and prevent you from getting an infection. And then the other thing I'd like to point out, because she was talking about the stabilization of mRNA, is that a doctor at LSU Shreveport, actually, Dr. Robert Rhodes, he actually developed the patent for stabilizing of mRNA. And so he actually, they licensed that to Pfizer and BioNTech. So it's pretty cool. But I think eventually, LSU Shreveport will kind of get some credit in helping to control this thing across the whole world. So it's pretty neat.
That is always good to get some good publicity for Shreveport. I'm not sure who to direct this question to, so first come, first serve. But continuing on this thread, and it's one of the questions that has come up in the Q&A, and certainly one that I know is out there. Given the really remarkably accelerated development of this vaccine, although Dr. Murphy, your information about the history was really interesting and one that I was not familiar with. How do we alleviate people's fears that there may be long-term consequences that we don't know anything about? Is there any way to address that concern?
Well, I could start with that question. Even though these vaccines have had a remarkable success in being developed and then given emergency use authorization in a very short period of time, they've gone through all of the safety studies that every vaccine that we have licensed in the United States go through. We have accelerated the process by having people work together to try and minimize the time between different aspects of development, but safety has always been the primary goal for each of the phases of the studies that led to the emergency use authorization. In terms of long-term sequelae, we've now given this vaccine to millions of people, and it's turned out to meet the safety requirements that are similar for every other vaccine. It's turned out to be a very safe platform for vaccines. So the expectation of chronic issues related to this vaccine would be virtually none. It would be minimal because, as Dr. Murphy said, we're dealing with a small molecule that is programmed to enter a cell to then do its job in the cytoplasm, produce the protein that we then respond to, and then disappear. So that there is no residual. And so as terms of a safe platform for a vaccine, this has pretty high marks. So I think I would not expect to see any significant chronic outcome related to this vaccine. It's a very safe approach.
Dr. Holloman, I'd also like to add that something I always tell all my patients when they ask me about this is that we do know that there are plenty of long-term side effects of getting COVID. We all know many doctors who have gotten this disease, nurses and frontline workers who have, been in the ICU and been sick, but then once they recovered, God willing, they had after effects, headaches, permanent loss of smell, paralysis, you name it. So I just remind people truly of the data. We do know that this virus does have long-term effects.
Thank you. Yeah, that's a really important point. And in general, I think one of the things that those of us in trying to work with this in other ways, wrestling with this question of risk mitigation and helping people understand that this is one of many, many risks that we take every day, and we have to really learn how to talk about those and think about those. And as somebody who dabbles in one aspect of behavioral economics, those kinds of framing questions are really hard. And again, Dr. Murphy and some of our other faculty colleagues at Centenary have done a great job helping us think about the balance between physical health and mental health, and as we deal with this and some of those questions. So but the risk, whatever sounds like very minimal risk of the vaccine, are certainly outweighed by the risks of the consequences of having the vaccine, of having the disease. Thank you. Dr. Massey, I'm going to turn to you again. I think we're going to move to some fairly practical questions about the vaccine, and we know, I think we've got pretty good information already out there around where the state is in terms of the process, although again that changes every day, as we saw with the announcements from from Christus and Willis Knighton yesterday. So we're moving into partnership with our friends at Ochsner LSU. Help us understand about when you get the vaccine. Do you have to, how long do you have to wait for the next round, and some of those questions. I'll follow up as we continue to talk.
Yeah, it depends on the vaccine. Right now at Ochsner, LSU Health, we have the Pfizer because that was the first one that came out. And so that one's 3 weeks, and then Moderna, I believe, is 4 weeks between getting the first and second dose. So it just depends on which company makes the vaccine you're getting. When you get the vaccine, you're going to wait, and this is part of which phase of the data we're in right now. So basically, now that, like Dr. Bocchini said, millions and millions of people are getting this vaccine, and so we did find out that very rarely. So probably people are going to ask this question about allergies and allergic reaction, but extremely rarely people do get an allergic reaction. And so once that data came back, then we just say, okay, well, we need to monitor people for an allergic reaction. So you are monitored for 15 to 30 minutes for an allergic reaction. But as far as I know, we haven't had a single one in Shreveport. And it's out of millions of doses. We've got, I think, Dr. Bocchini, what do we have, 40 million doses that have been administered, I think, or distributed, and 20 million that have been given, something like that.
Yeah, that's the right ballpark. About 40 some odd million and 20 some odd million delivered. Yeah.
Yeah, and maybe only a handful of reactions in the United States. So it's very, very rare. So.
And I've got a question here. I think it's sort of 2 levels. Make sure we're clear and accurate in our answer. Obviously, if you receive the vaccine from one supplier, one of the vaccines, you have to make sure that your second one is the same manufacturer, correct?
Well, I think the FDA just announced that they're actually going to say that it's okay if, because due to supply chain issues, it may be that you won't be able to get one from one versus the other. And I think they're going to announce, or they already may have announced, Dr. Bocchini might know about this, that you can get the other one if you have an issue getting it.
That's true. That the standard approach would be to get the same vaccine for the second dose as you've had for the first. But the FDA and the CDC now recognizing the possibility that there might be significant delays and significant difficulty getting that second dose from the same manufacturer, has indicated that under extreme circumstances or special circumstances, they are willing to allow you to get the vaccine that's available. But I think for right now, the approach ought to be to try and get the same vaccine. And the way that Louisiana has been setting up its distribution is to make sure that those sites that gave the first dose of a Pfizer or Moderna vaccine are going to get the same allocation 3 weeks or 4 weeks later for those people to get their second doses. So unless there's a serious manufacturing problem, there should be the opportunity for most people to get the second dose at the same time. With the same vaccine they received for the first time on time. Now, the other thing that the CDC has stated is that if you're a little bit behind in getting that second dose, it's okay because it's not going to interfere with your immune response. But we don't want to delay too long because that interferes with you getting the maximum protection that you get after the second dose. So we want to try and get that second dose in with the same vaccine that you got for the first dose on schedule whenever possible.
I want to come back to that question of the immune response curve because we've got several questions on that, but I want to drill down just a little bit. I may be reading too much into this question, and so and this may be just completely hypothetical, but if someone gets the Pfizer vaccine from one distributor at one location, it doesn't make any difference. They could get the second Pfizer from somebody else, right? I mean, there's nothing magical about who administers the vaccine.
Correct.
Okay.
But like Dr. Bocchini said, everywhere we have some excellent healthcare systems in Shreveport. We are so blessed with Willis Knighton, Christus Schumpert, and Ochsner LSU. and they've been very good at reserving your second dose. So you'll get a card after you get that first dose, and that card has your date for coming back at the appropriate time, and then they actually reserve your second dose of the same vaccine.
So no reason to make this more complicated than it is.
Right.
So, and before we turn to the immune response, or maybe a transition question, we do have a question from the audience about the Johnson & Johnson single dose vaccine. Do we expect that to be as effective as the current option? I guess we saw today in the news, one manufacturer, Merck, I think, said they were stopping their development because those weren't as effective. What are we hearing about the J&J vaccine?
So the J&J, the Johnson & Johnson vaccine, the manufacturer expects to get to enough outcomes, and outcomes are the number of infections amongst recipients in the clinical trial, that they're very likely going to have that data be reviewed by their data safety monitoring board. So every vaccine that's being tested the results are evaluated by an independent board that then rules on whether the outcome looks significant enough to then present the data to the FDA. And then the company puts that data together, goes to the FDA. So we may be a week or so away from Johnson & Johnson submitting the data to the monitoring board. If they approve the going forward to the FDA based on how effective the vaccine is and how safe it is, then that's probably another 2 weeks or 3 weeks before it goes to the FDA. So at this point, we don't know how effective the vaccine is. And so when they break the code with the safety monitoring board, they will have our first real look at how safe and how effective that vaccine is.
So,
and again,
still really to be determined.
To be determined, and to make sure that everybody had an equal playing field, the NIH has really designed the clinical trials for each of the vaccines that are in study. And so the phase 3 trials have to be the same, minimum of 30,000 people, half of whom get the vaccine, and then looking at least 100 plus outcomes before they do the safety monitoring review.
And Dr. Murphy, this goes a little bit to some of the conversation we had with Dr. Massey a minute ago, but I heard a good conversation on NPR this morning. Help us understand the difference between the flu vaccine, the seasonal flu vaccine that we get, and this COVID vaccine, because we're all familiar with, we take the flu vaccine and we still get the flu, or other people still get the flu. We don't see these kind of 90% effectiveness rates that we're being told that we have with these. Help us understand why that's the case.
I think there are a lot of factors that go into that. I think one of which the flu is, as many different strains as we're seeing coming from COVID. I think relative to being a virus, it's not as quickly mutating as maybe some others are. And so we see with the flu, this is a fairly rapidly changing virus. And so what happens, and this is again just kind of surface level information, is that vaccine manufacturers have the task each year of trying to choose from the different strains that may be circulating, which ones will be the dominant strain. And so they create a vaccine, and these vaccines again are more the flu vaccines are more of the traditional type, where we have like the weakened attenuated, etc., those types of viruses. And so those are really, compared to the RNA-based vaccines, they're a lot more time consuming. You hear all about, we have to start a year in advance, we have to grow them in eggs, etc., those types of things, and that just takes a lot of time. And so by the time you figure out for sure, okay, this is going to be the dominant strain this year, unless you have a flux capacitor, you can't really go back and remedy that situation. Nice. And so I think that that's one of the things that plays into this. I'm sure that Dr. Burkini and Dr. Massey may have something to add with that. And so this is, you can get strains that are really not covered by the vaccine. One of the things that I would really praise about these mRNA vaccines is how fast they really are to get into production. So I was actually reading, I think this was the Moderna vaccine, which again, RNA based, just like the Pfizer vaccine. I believe that they sort of stated that they went from the day that they got the sequence of the spike protein to the time when they could turn around and start manufacturing this for trials and testing was less than a week. And so it's just really the speed. And so I think one of the things that will be really helpful is if we do have some of these emerging strains, like I think the variant from South Africa that we're just now starting to hear about. One of the concerns with that is that our vaccine that we have now, they think that our vaccine may cover it, but perhaps not. I think that, you know, we'll have this sort of system in place that at least for production, so I can't really speak to distribution of vaccine, but these are just a lot faster. So I think I added in some extra information just because I was, you know, reading about this and really amazed at some of the speed. But hopefully that was most of, I think, the question that you originally asked.
Yeah.
And again,
So in some ways, I mean, to use a crude analogy, you know, the traditional flu shot is trying to hit a target that we don't even know very well with a shotgun, whereas this, we know where the target is, and we've got sort of a sniper rifle that we can really aim at it very closely. At least that's my layman's attempt at it.
and I think one of the,
Go ahead.
sorry, it's Zoom, it's really difficult to read social cues when it's your turn. I think one of the things I just wanted to add is, you know, there's even talk already about how this RNA vaccine technology can be used to better optimize flu vaccines in the future so that we're not missing the target. So that's like a bonus, like add-on fact, but.
So thanks. Let's go back to this question then of immune response. So several questions about how long after the first, you know, how safe are you after the first administration? How long after you get the second? You know, where's your immune level after that? And do we think this is going to require a booster shot at some point? So who's got some good information for us on that?
Patrick, you want to start? You want to give me?
Yeah, I know. So realize all this is based on these initial FDA studies. So the truth is we really don't know. But based on the small sample size of patients, which, you know, is at this point hundreds of thousands, after one dose, I read one study that said you can be, you know, up to 80% immune, basically. So there's like an 80% reduction. And then after 2 doses, of course, you get to that 95%. Dr. Bukini, you want to add anything?
Yeah, and I think that 80% number, we really are encouraged by that, but it's really based on a very small number of people who turned positive versus those who got the vaccine. So we don't feel that's a really hard number. It'd be great if that's true, but that's the number that's being quoted. The best benefit occurs somewhere between the first and second week after the second dose, which is when you get to 95% protection. So it's really important that that second dose be given and that you don't expect full immunity until at least 2 weeks after that second dose.
And one of the questions that has come up several times also is, so after, let's think happy thoughts, and after we get our second dose, does that mean that we are both protected from getting it, and are we also unable to transmit the virus? Is that true?
So that's a complete unknown. You know, that we don't know. We do know that the vaccine prevents symptomatic infection. And so that data is very strong. In terms of being asymptomatic infection, we have no idea at this point in time. So whether a person who's completely immune, who's protected from symptoms, can get the virus and then carry it for a period of time and then spread it, we don't know yet. So that's one important reason why we're not going to suggest that people who are fully immunized go out and and don't have to use the typical mitigation strategies that we think are so important. And the second reason we don't want to do that is because people may be in that 5% and still be susceptible to the virus. So we're not going to change the mitigation strategies now while there's so much virus in the community, even for people who have received their second dose. And then the other question that you asked about duration of protection, that's another complete unknown. The vaccine hasn't been around long enough to know how long the protection will last. We do know that from the natural infection with the typical human coronaviruses that circulate, we only get protection for 1 to 2 years, then we become susceptible again. This virus, we don't know how long natural infection will produce protection, but this expectation is it'll be very similar. And the expectation for the vaccine is that it's going to provide better protection than the natural infection. So whether we need another dose in a year, just like flu, or every 3 to 5 years as a booster, it's unknown, but those are real possibilities that we'll learn more about based on following the people in the original vaccine trials to see those who are protected when we start seeing a reduction in immunity and some cases in those individuals who had been protected.
Okay, thank you. And I just, because we do have several questions, I really want to underline one of your points because I think it runs counter to a lot of what some of us are hearing, that we just really don't know, even after 2 weeks after you've had your second dose, you may still be able to transmit the virus. And just want to make sure that some of the people that have been asking about that hear that loud and clear, and keep with our mitigation strategies and our good habits and so forth. We've got about 15 more minutes, and I already see sort of 3 clusters of questions out there. I think the next easiest place to go is to find out what you're hearing about the situation in Louisiana. When will the rate of vaccine availability speed up? What do you see in the way you run the numbers about progressing through the phases? I know about a week ago, the governor said his standard was we weren't going to move to the next phase until 20% of the appointments were going unspoken for. I don't know if that's still the case. I know that there are a number of us in higher education who see that in Arkansas, the higher ed people have been put in the same phase with K through 12. Questions about that. A lot of people I know that are falling into this 65 and up gap that are interested and anxious to get the vaccine. So Dr. Massey, I guess I'll turn to you first, just because I've seen how up to date you stay on protocols and things like that. So what are you hearing?
Well, I just read today, across the country, they're increasing some of the doses, and I saw John Bell Edwards, they had a press release that we got an increase of 16% for next week on doses. So I'm just reading this from an article, but basically, let's see, they expect 30,000 Pfizer doses and 38,000 Moderna doses next week. And so that's a total of 67,000 doses for 1 week. That's up from about 58,000. So they're steadily increasing the number of doses. And one thing that's interesting, that when this first came out, and it was mainly healthcare workers, most of the healthcare workers, a lot of the younger ones didn't want it because they said, we're young, we've been dealing with this for a year, we've been exposed to it every single day. We'll kind of wait till a lot of our patients have gotten it. And I know a lot of healthcare workers that did that. And then as soon as they increased it to where some of the elderly sick people were getting it now as soon as it gets on the shelf, it's given. So I really think that was kind of the key. The first couple of weeks of this, there actually was almost like a surplus of vaccines. So now we're definitely getting all of them out there in people's arms right away.
Dr. Bocchini, do you have any sense of what percentage we've covered in the current phase? So that, what's the gap between eligible people now, and when we can maybe think about expanding eligibility?
Well, I think we still have, at the rate that Dr. Massey was talking about, we probably still have another 4 weeks of trying to get to the current population that's been identified before we get high enough to go to the next phase or broaden it to the next group of individuals. I think that one of the things about Louisiana in the listing of states in terms of how good we've been in getting vaccine that was distributed to the states into the arms of people for whom it was indicated, Louisiana was the 8th best in the country in getting vaccine into people's arms as of about a week and a half ago, but we were still at 47%. So that's still not good enough. I mean, we need to try and get as many doses in every week as we get. So we need to keep getting that number higher. So I think it's going to take at least a month to get through this phase before we open it up even more broadly. But as you said, Dr. Holloman, every state has been a little bit different in how they've approached trying to get the vaccine out and into as many people as possible, and have made the judgments based on, you know, the two judgments are, do you try and get the people that are more likely to have severe disease, or do you go after the people who are more likely to spread it to try and control this pandemic? And if we're following the general guidelines of the CDC and the Advisory Committee on Immunization Practices, which Louisiana is, we're going to try and get the most vulnerable, which are nursing homes, chronic care facilities, and the high risk, which are physicians and other healthcare workers that are seeing patients every day with COVID, and then expanding beyond that. And I think it's going to take a while for enough vaccine to be present for us to get into the next groups.
Well, I wish the answer was different, but I will live with that. Dr. Murphy, I know, changing gears just a little bit, we still have some sort of a group of questions out there about overcoming resistance to the vaccine and helping people get comfortable with the idea. I know you've done some research and reading around some of the myths around the vaccine. You want to do a minute or two of myth busting about the vaccine?
Sure, and I'm certain I won't cover the entirety of the internet with all of the myths that could be out there, but I've tried to kind of see some of the ones that I've found that they pop up most commonly. So one of the big ones is that the vaccine, like mRNA-based vaccines, can edit your DNA somehow or change your DNA. So I'd like to talk about that a little bit. So we've already discussed how basically fragile these mRNA molecules. It took decades of research just to be able to get it stably into the cell. And it is designed to basically do its job and then be cleared from the body naturally so that there isn't really any remaining trace of this RNA left. And I'd also like to point out that RNA, just in general, messenger RNA or mRNA, you have so much of it in your cells already just that you produce. This is one of those sort of natural processes that you may remember from high school biology, overshadowed by mitochondria being the powerhouse of the cell, of course. But this is, you know, the DNA, we make a copy, it's RNA. That's how we get the proteins that we need to live. And so your cells are very aware of what RNA is. They're not interested in incorporating it into the DNA. If that was a thing that our cells wanted to do regularly, we'd be doing it to our own RNA. We really have problems at that point. So there's really no risk of it being able to change your DNA at all. Again, it's designed to be transient in the cell. So I think that's one of the strengths of it. I think some of the other things that I've seen pop up, one of the big ones, and I've had people personally ask me about this, and I think it's important. I've seen some talk about risk of this particular vaccine causing infertility in women. And of course, this is you know, obviously if this were true, this would be something to be very concerned about. So I think for this particular myth, it's important to kind of understand how this myth came about. And so at some point on the internet, I guess someone decided that the spike protein itself had some similarity in shape to a protein that's important for helping form the placenta during pregnancy. So just because I guess I'm a little bit extra, and I do understand, you know, I hear you, this would be a concern for people who are looking to have children. I actually pulled the sequences, like the actual sequences from database for both the spike protein and this placental protein and compared them to see how similar they actually are. And the TLDR, the answer is not at all, like not even a little bit. So that's kind of point one. I think just to give it a little bit, maybe add a metaphor in here or something, it would be like mistaking Harry Potter and the Chamber of Secrets with Moby Dick because they both have the word "and" in it. Your body's
Nice.
your body's
Nice.
not going to make that mistake. Antibodies are highly specific. Like, look how much trouble we're trying to go to just to get it to recognize the right thing in the first place. While sometimes antibodies can make mistakes, I think the similarity of these two proteins, it's just, there's just no way. I barely could even, you know, using the algorithm, barely even get it to align at all. There's just really not any similarity there. I think kind of second thing to think about is, again, the worry is that the antibodies made to the spike protein in the vaccine will cause this. But it's important to remember you're getting that exact same protein in an uncontrolled way if you get COVID. And it comes with all the inflammation, all of, you know, the damage. I mean, like, the difference really, you get the same virus, the same RNA, the same spike, whether you take the vaccine or get COVID, but COVID is there to mess you up. The vaccine is controlled. And so I really think that, you know, there's not any real risk of this. And of course, if Dr. Burkini or Dr. Massey have anything to add, those have been the biggest two that I've seen.
Well, that certainly goes back to Dr. Massey's point about consider what the alternative is if you get sick. Thank you. I want to, well, I glossed over one very important practical question, and I want to make sure my information is right. There was a question from the viewers of just making sure this vaccine is free, right? There's no cost. We're not billing insurances for this at this point. Is that correct?
Yes, the vaccine is free. The vaccine has been purchased by the federal government to cover everybody in the United States. The insurance companies will pay for administration of the vaccine.
Okay.
But if someone doesn't have adequate coverage from an insurance company, they can get the vaccine. That's not going to be a problem.
Okay, thank you. The last set of questions, because we're down to like just 5 minutes or so, but I'm really gratified by this certain group of questions because as you maybe can tell from my background, I'm an international relations scholar, and we've got a few questions about COVID in the world and questions involving herd immunity. You know, can we have meaningful herd immunity for the United States alone, or do we have to have sufficient vaccinations around the world, and what are we feeling about the availability of vaccines in poor countries? I see that I've got several. We've got several of my fellow Rotarians on the chat, and of course Rotary has worked really hard with the eradication of polio, and so those folks know some of the difficulties of getting those last few cases of polio knocked out. And I'm not sure who's best equipped to answer that, but be interested in your thoughts around what's the global reach and the necessity of getting this vaccine distributed globally.
Well, I'll start. It is a global issue, and we do need protection around the world to be able to control this pandemic. And the estimate for this virus is that we need 70 to 80% of the population immunized to provide enough herd immunity to reduce the spread of this virus within our communities. So it has to be a worldwide effort. One of the potential advantages of the Johnson & Johnson vaccine is that it's a single dose. It only needs the routine vaccine temperatures for cold chain management of it to get it out to rural areas. So it could be an incredibly big factor in taking it to poor resource countries and into rural areas to try and get more people vaccinated. But yes, we need a worldwide effort to control the pandemic, and we won't be safe until we have that.
We've got one question that we can probably just, I don't know if we can do it as a show of hands. Have any of you gotten the vaccine? I have not, but I'm ready. Somebody shows up at my door. Our two physicians have, and I suspect Dr. Murphy and I are not eligible yet. I know I'm not, and she's a lot younger than I am. So, Dr. Murphy, you haven't, have you been vaccinated yet?
I haven't, but I'll take whichever one is made available to me as soon as it is.
Well, and we just learned 2 nights ago that Centenary has been approved as a vaccination site. We do have a super cold refrigerator. We're not sure how that will play out. As I said, we saw yesterday that for our region, it may work better to pool our resources into a more efficient single site. So, but stay tuned for that. So our 2 MDs have gotten it, and the other 2 of us are just waiting our turn and ready, willing, and able when the time comes. For our last little, in just in a couple of minutes, Dr. Massey, again, I know you've done such a good job with our athletes here at Centenary, helping them understand the importance of getting tested and some of the kind of messaging issues. A couple of questions about how do we get the word out? How do we get the word out and get people complying better about mask wearing, and much less the vaccination? I wonder if you've got any kind of closing thoughts on that.
Well, you know, what we're doing right now, good example, and just more things like this, but also just finding people, just word of mouth, remind people that the sooner that everybody gets on board with things like mask wearing, and it's an apolitical thing. It doesn't matter where you stand. The sooner we all get on board with it, the sooner we all return back to normal life.
That seems like a great place to stop, and we are right at 7 o'clock. So I want to again thank everyone who attended. We had a great group of people. I'm very pleased that Centenary is able to provide this service. Thanks to our panelists. I want to thank the provost at Centenary, Dr. Karen Soul, and Lauren Calloway in her office, who did a lot of the behind the scenes preparation. We also had great technical support from Cheryl Anderson and the folks in the IT office. If I think we got to most of the questions, but if by some chance we didn't, I'll take the point on that. Email president@centenary.edu, and I won't answer it, but I'll find the person who can answer it, and we'll try and get you the information that you need. Thank you again, everybody, for being here tonight. Once we get back to, as Dr. Massey said, something close to normal, we would love to see you on campus. We love having the community with us, but not till we're safe again. Thanks again, everybody. Good night.
Thank you.